I'm back. Hello again for continuation of our study. So this is the spinal cord injury. So remembering the function of the spinal cord is relay center of spinal nerves, sensory and motor pathway going to the brain and to be interpreted by the brain. So spinal cord is also very important because this is a thread-like structure wherein the spinal nerves arises from cervical to coccygeal. Okay, so now the most frequent vertebrae affected wherein compressing or cutting the spinal cord is from C5 to C7 and then T12 to L1. Why? Because the C5 and C7, they are more movable. So like on the neck area, they are movable and easily can compress the spinal cord, and as well as your T12 to your L1. Okay? So on the pelvic area, they are movable. Okay, so could be compressed, could be transected, or it could be had a contusion or being injured with a certain forces or a blunt object. So those are for the spinal cord injury. Okay, so as you can see here, so these are your bones, the vertebrae that protects. So eventually, when they are crushed together, so that your spinal cord could be compressed, there would be injury. Okay, now when spinal cord injury occurs, so these are primarily the manifestation or the symptoms. You would have the paraplegia, quadriplegia, spinal shock, and autonomic dysreflexia. The moment they are had an injury, either you would have a flaccidity state or a state of paralysis or no movement at all. That's called flaccid, like paralyzed totally. And as the injury progress and development, okay, so there would be spasticity wherein the movement occurs. So this is state of muscle contraction that is so tight. Okay, so there will be a positive movement, but they are so rigid or spastic. Okay, now paraplegia, quadriplegia, spinal shock, and autonomic dysreflexia, we're going to talk about it. So here we go. So for C4 injury below, like for this one, this is cervical. So complete injury would have quadriplegia, like the upper and the lower extremities are affected. Okay, if you still have the cervical, so from this area, it's still quadriplegia because it affects your upper extremity and the lower extremity as well. Now thoracic, the T6 injuries from here below, you would have the paraplegia wherein it spare your upper extremity but it affects your lower extremities. Okay, and the L1 is the same. It affects your lower extremity but spare your upper extremity. So it means the upper extremity are still functioning and you could mobilize by using your upper extremity, but the lower extremities are affected. Okay, now for spinal cord injury test, diagnostic test, spinal x-ray to see if how your spinal cord is damaged. Spinal x-ray, CT scan, or the MRI wherein visualizing the tissues of the spinal cord. Okay, what we're gonna do during the moment of spinal cord injury, of course ABC is very important, airway, breathing, and circulation. However, if you suspect that the client had a spinal cord injury and you're going to provide breathing, maintaining the patent airway, do not tilt. Remember that as an NCLEX question, do not tilt because you further aggravate the condition. So let it be on neutral position and provide immobilization to the client. Okay, so that's why they sometimes say, if you suspect spinal cord injury, they neutralize this area, okay, and immobilizing the client, and immediate transfer to tertiary facility or the hospital. Nursing intervention, let's focus on this one. Promote adequate breathing and airway clearance in the hospital, okay? So by providing tracheostomy or oxygenation to the client. Improved mobility and proper body alignment, such as turning the client every 2 hours, range of motion, and proper positioning, okay? Promote adaptation to sensory and perceptual alteration. Neurovascular check for the client, because the client would have either a complete or incomplete sensory problem like tingling, no sensation, and no motor movement, okay? So have to explain what is going on to the client regarding that matter. Maintain skin integrity by turning the client every 2 hours and check the skin if there are abrasions or might possible of having a pressure sore, okay? Maintain urinary elimination is also important because full bladder, this is a full bladder would lead to having autonomic dysreflexia. This is most common, okay? So that's why maintenance of urinary elimination by catheterization or intermittent catheterization or catheterization for the client, so they could check the bowel, the bladder itself, if it's full, okay? It's well contracted, so you have to eliminate that, or else the client would have autonomic dysreflexia, which is hypertension, so that could be lethal to the client. Improve bowel function as well. No constipation, that's why the client need to be mobilized. Also provide fiber diet to the client, so to avoid constipation and avoiding Valsalva maneuver as well, okay? Provide comfort measures, so place the client in comfortable position wherein he or she could breathe well. And 8 is monitor and manage for complications. Usually a client with immobility or immobilization because of their flaccidity or no movement or paralysis, thrombophlebitis, TOSA is thrombophlebitis, orthostatic hypotension, spinal shock, and autonomic dysreflexia. Now, because stagnant blood could lead to thrombophlebitis, such as your DVT, okay? Remember, okay, check for DVT at all times. It's very important. So we were gonna tackle it sooner. Orthostatic hypotension, because the client is always in bed, so when you abruptly sit them, okay, so they could have the hypotension for the client, which is also lethal for the patient. Sorry for that. Spinal shock for the client, we're in the moment of no motor or sensory sensation, and autonomic dysreflexia. Okay, now talking about that, we're going to talk about that later. Assist client with surgical reduction and stabilization of the cervical vertebra, especially the cervical vertebral column. So they should maintain that position. That's why they put it, so it will not move, so for further aggravation of the injury. Now, speaking of autonomic dysreflexia, this is commonly seen above T6, okay? So remember that, above T6. So T5, T6, injury, okay? So anything that is above T6, that would cause you to have autonomic dysreflexia. This is an exaggerated response by autonomic nervous system resulting from various stimuli. Most commonly, as I've told you, is a full bladder, okay? Impacted or feces or constipation, stress, pain, or skin irritation. That would cause you to have autonomic dysreflexia. But if they're going to ask you, you always choose the distended bladder, okay? Next, what are the manifestations of your autonomic dysreflexia or hyperreflexia? So the client would have the hypertension, okay, hypertension, increasing blood pressure, that would also complicate the client. destroying your internal organs. Okay, bradycardia. Okay, decreased heart rate. And also the client would experience severe like pounding headache. So they would complain, they would shout because of too much headache they were experiencing, and profuse diaphoresis or profuse sweating. So observe for these symptoms, and eventually you would see that the client is having autonomic dysreflexia. If that is, then of course have to report it to the doctor immediately. Okay. And the client will have nausea and nasal congestion as well. Okay, what we're gonna do with autonomic dysreflexia is that elevate the head of the bed immediately. Okay, remember that this would help the client to circulate. Okay, circulate the blood and everything for the client. Check, of course, assess or check the bladder if it's full bladder or distended, and had a catheterization. Check also for fecal impaction or constipation and other triggering factors like skin irritation and pressure ulcer that the client is experiencing pain. Administer hydralazine or your antihypertensive drugs. It's ordered by the doctor and you have to give that. Okay. And that'll be all for the spinal cord injury and autonomic dysreflexia. I hope you learned from that. If you have questions, please comment down below. Thank you. Have a nice day.